Good afternoon, everyone, and welcome back to our CHPRE Health Policy webinar series related to COVID and taking a look at COVID from different lenses. Today, we have three experts on insurance and Medicaid coverage, and we are delighted to have them here to talk to us about what we can say and what we have learned so far about this pandemic, insurance coverage, and Medicaid. We're going to start this afternoon with Linda Blumberg. She is a fellow at the Urban Institute and is an expert on coverage topics. And we are delighted to hear results from your team's latest work on your health insurance policy simulation model. We also have with us Ellen Montz, who is the Chief Deputy and Chief Health Economist. You have a long title, Ellen, at DMAS, which is the Medicaid agency in Virginia. And she will tell us about what Medicaid is, what their struggles are and their successes so far in Virginia. And Jeanette Thornton comes to us from America's Health Insurance Plans. She has been with AHIP for 15 years and is an expert and chief legislative and regulatory affairs person at AHIP. And I'm sure you have your hands full as well also. And we look forward to hearing about what AHIP's priorities are in the pandemic and going forward into the coming year. Let's start, please, with Linda. What can you tell us about the economy and our insurance projections?
So, first of all, good afternoon, and thanks for inviting me to be part of your panel, Alison. And I'm going to talk about an analysis that I did with a number of my Urban Institute colleagues. And this work was funded by a grant from the Robert Wood Johnson Foundation. And I want to draw attention specifically before I jump into things to the title of this work, which in quite atypical form for us, we refer to explicitly as preliminary. We do that because of the extraordinarily unpredictable times we're in as a way of acknowledging that it's practically impossible to accurately predict what path the economic changes that we're facing during the course of the pandemic are going to take, and that we recognize that as time goes on, we're going to have to use more and more recent data to update these findings, but that this is the best that we can do given the knowledge we have at the moment. Let me see if I can figure out how to move these slides forward. Okay, there we go. Oops. Okay. The coronavirus pandemic has obvious to everyone upended the U.S. economy. 23 million workers had lost their jobs in April. At that point, the official unemployment rate had reached 14.7%, but it would have approached 20% had it been adjusted to include people out of the workforce for unspecified reasons, which is probably a more accurate way of looking at what was going on. Despite some employment gains in May and June, most economists have forecast a long and slow economic recovery. The Congressional Budget Office has projected that employment losses will average 22.4 million people in the last 3 quarters of 2020. And that is a projection that we are using to kind of ground our estimates, and I'll explain that as I go forward here. So the key questions that we're trying to answer with this analysis included: how many people are losing their employment-based coverage due to the 2020 recession job losses? And as a consequence of those job losses, how many people will become uninsured? And third, how well are the safety net programs, namely the Medicaid expansion and subsidized non-group coverage through the Affordable Care Act's marketplaces, working? Are they catching people as they lose insurance coverage during this extreme economic downturn? Okay, so we use the Urban Institute Health Policy Center's Health Insurance Policy Simulation Model, which we shorthand with the name HIPSIM, to answer these questions. And a microsimulation approach allows us to take full advantage of available data on who is losing employment, incorporating those details into estimating who is losing health insurance coverage as a consequence. We use detailed information on the characteristics of people losing jobs, which is made available monthly by the Bureau of Labor Statistics. The monthly data release includes demographic information as well as job losses by state and industry. And what we have seen thus far is that the hardest hit industries include restaurants and bars, hotels, travel, as well as healthcare and state and local governments. Now, our microsimulation model, HIPSUM, has at its core 2 years of the American Community Survey, which means that it has 6 million observations and is representative of the U.S. population. The model has been aligned with pre-COVID 2020 data on insurance coverage, the uninsured, premiums, and healthcare costs. So we take that 2020 full employment version of the model, and on that base, we simulated employment losses among workers in the model who match the characteristics of those actually losing employment by industry, occupation, education, gender, and part-time status. We also target total simulated employment losses by state, and we control the overall number of job losses to that estimate I mentioned before, CBO's projection for the last 3 quarters of 2020. So you could think about our estimates as an average effect over the last 3 quarters of 2020, basically the COVID-19 recession period. We then calculate the change in income resulting from the job losses for each individual and family, taking into account the detailed rules regarding unemployment insurance benefits. We use, and those vary by state and have changed as a consequence of some of the federal stimulus legislation. We use those new recession period incomes to simulate the eligibility of each person and family for available health insurance assistance programs, and we estimate the take-up of those insurance options as they have changed for each person and family. Okay. So I'm going to give you the big picture findings and then explore them a little bit more in depth. We estimate that 48 million Americans below the age of 65 live in a family with at least one COVID-19 related job loss this year. Among those 48 million people, we estimate that about 10 million will lose employer-based insurance coverage that was tied to a job that was lost in those households. Now, of that 10 million losing their prior to the pandemic job-based coverage, we estimate that about 3.5 million of them will become uninsured. Okay. So our estimate is somewhat lower in terms of the effect than estimates by some other analysts, and we can talk about that. We can talk about that a little bit later. But yet our estimates are consistent with the evidence that the current recession is affecting some industries, but affecting others not at all or very little. We find that as a result of these differential effects across industries, that most of the workers losing jobs did not have health insurance coverage tied to those jobs to begin with. However, it's clear that the recession is still unfolding and affected industries could change, and the distribution of job losses across states could well be changing as well as we see the pandemic surging in different areas of the country than where it had its greatest effects early on. All of these kinds of changes in direction could affect these estimates going forward. Okay, so the pie chart, the first pie chart I'm showing now, which is figure 1 on the left, shows our findings on pre-pandemic insurance coverage for the 48 million people and families suffering at least one job loss during the recent months, or over this period, I should say, the last 3 quarters of 2020. We find that a little over 1/3 of these people had employer-based insurance through a family member who did not lose a job in the recession. So it was, they had ESI, but it was through somebody else, not the person losing their job. 27% had Medicaid or CHIP pre-pandemic, and about 5% had non-group coverage, and about 10% were already uninsured prior to the crisis. So only 21%, or 10.1 million people in this group, had employer-based insurance through a job loss due to the pandemic. Now, the pie chart on the right basically takes that 21%, that 10.1 million people, and breaks it down into how their situation is going to, we estimate, is going to evolve over this period. And what we find there is that roughly a third of them would get employer insurance through another family member. Somebody else also had an employer offer, and then the family, we estimate that a very high percentage of them will take up that other offer. About 28% would get Medicaid or CHIP. About 6% would get non-group insurance coverage, mostly subsidized through the marketplaces, and about a third, or 3.5 million, would become uninsured. Okay. So now this figure shows the net changes in health insurance coverage for the entire non-elderly population in the U.S. when we take into account all the movements that occur between different insurance options. So here you see that on net, employer-based insurance decreases by 4.8%, or 7.3 million people. This takes into account the people losing their employer coverage and those able to take up another policy through another family member. We also see non-group insurance coverage going up on net slightly by 200,000 people, or 1.3%. That net estimate takes into account that about 700,000 people would newly enroll in non-group coverage, but about 500,000 people that had coverage through the non-group market pre-pandemic would experience income losses that meant that their incomes were too low to be eligible for marketplace subsidized coverage. Many, though not all, of these people would become eligible for Medicaid and CHIP. And the increase in Medicaid and CHIP that I'm showing here in this table takes into account not just those enrolling in that coverage when they lose employer insurance, but also some moving out of non-group due to income losses, and even some people who were uninsured prior to the pandemic who also experience income losses when there's a job loss, and now they're eligible for Medicaid. And enroll in that. So on net, we're estimating an increase in the uninsured of 2.9 million people, or 10%. Okay. Now this double table here shows those same findings, but separated for people living in states that did expand Medicaid coverage, and in the 15 states that have still not expanded coverage. I'm including Nebraska here and the non-expansion states. They are supposed to expand eligibility as of later this year, but still have not done so. And we never, as a matter of course, count a state as being an expansion state until they actually are enrolling people in the program. And so what we can see here is that workers in expansion states were somewhat more likely to have had employer-based insurance through their jobs that they lost pre-pandemic, the jobs they had pre-pandemic. So their employer-based insurance levels dropped to a somewhat greater degree than workers in the non-expansion states. You can also see that because of the higher levels of Medicaid eligibility in expansion states, the relative increase in Medicaid and CHIP is more than twice that in the non-expansion states. And in the non-group coverage, we see that in expansion states, there's a small net decrease as the number of people newly enrolling in subsidized coverage is outweighed by the number of people with prior non-group coverage who are newly moving into Medicaid due to having income losses. Okay, so let's talk about this in terms of how well these programs have served as a safety net during these economic troubling times. So focusing first on the expansion states, which is where the ACA reforms were working largely as originally intended, absent the individual mandate. And we found that 2/3 of those losing their employer-based insurance coverage end up obtaining coverage through another source, with about 1/3 becoming uninsured. Medicaid and CHIP enrollment increased by more than 7%. And we see that non-group declined slightly, as I mentioned, disguising the gross increases in enrollment that are offset by decreases in in enrollment as more people move into Medicaid. However, it's possible that going forward in 2021, that non-group would increase very noticeably on net during the next open enrollment period. Maybe during the discussion, we could talk about why we don't think why we're not seeing that yet, but that we could very well see that towards the end of the year. And then in terms of the non-expansion states, more than half of the people who lose employer-based insurance become uninsured, as opposed to a third in the expansion states. Medicaid and CHIP increases by a much smaller amount due to the much more limited eligibility, but we do see a very noticeable increase in non-group coverage as people are much less likely to move out of non-group and into Medicaid in these states. And I think I'm kind of at my time here, but we can talk about these other studies in more detail during the discussion. But suffice to say that our analysis is really the only one of the ones that is out there that is able to take into account all of the different transitions across the different types of coverage. It also allows us to really do detailed simulation of eligibility of those that are losing workers that look like those losing coverage according to the data that we're getting from the Bureau of Labor Statistics. But we can talk about the differences across these estimates later if people are interested. But I don't want to jump on anyone's time, so I'll stop there and we can talk more after.
Thank you, Linda. Thank you very much. And this is a good time for me to remind our audience that we are taking questions. So just put your question in the chat, and we will forward your question to our panelists when they are finished with their presentation. So we turn now to Ellen Montz. Tell us how things are looking from the standpoint of Medicaid. And of course, Virginia is one of the expansion states that Linda was referring to. What are you all facing?
Yeah, good afternoon, everyone, and thank you to Alison for having me here today. All right, I'm going to talk about our state Medicaid program challenges in the face of the COVID-19 emergency, and I'm going to talk about it in kind of three different buckets. First, our members, of course. The challenge here: how do we ensure that our Medicaid members continue to get necessary care during the COVID-19 emergency? Our second bucket are providers. How do we ensure that Medicaid maintains a provider network able to service our members during and, very importantly, after the pandemic? And third, our state budget, of course. How do we ensure a robust Medicaid program as Medicaid demands a greater share of a contracting state budget? So let me begin with the challenge of our members. At Medicaid, our primary concern is enrollee health. And this crisis has also meant the concern for the health of the growing membership of our enrollees. Since about mid-March, we've added over 115,000 new members to our program. So we're approaching an additional growth of 10% since the beginning of COVID-19. So when we thought about, as a Medicaid program, policies to implement in response to COVID-19, we put forth policies that would balance member safety with the need for medical care. So altogether, we put out dozens of policies aimed at this goal. But let me give two really strong examples of the member-focused policies we put out to kind of ensure access to care while also taking into account safety. So first, we announced that we would reimburse for telehealth. And for the Virginia Medicaid program, this is a new policy for us. We also announced that we would pay for telehealth at parity with in-person visits. So reimbursement would be the same for providers, whether they saw patients in person or whether they saw an individual telephonically or over the internet. So as I mentioned, this is brand new to Medicaid, but it was really a way to balance and ensure access to care. A second strong example here of policies that we put forth for our members is a policy that allowed methadone providers to prescribe or dispense greater than a one-day supply at a time. And this policy used recent guidance from SAMHSA on kind of safety of the dispensing of more than one dose of methadone at a time to actually respond to COVID-19. So those are two strong examples here. In these two policies alone, we've seen dramatic effects in our data on this goal to preserve access. So we are seeing them work in real time in order to preserve access. Second, we have the challenge of our healthcare providers. You know the story here. Elective procedures were canceled during the initial phases of COVID-19, and even now, utilization has been slow to return. This has meant dramatically decreased revenues for many provider types, not all, but many. And this is a particular concern for Medicaid over other payers, I would say, because many of our providers in our Medicaid networks are unique to Medicaid and already, prior to COVID, already operate on the slimmest of margins. And for Medicaid, we need to think, we need to make sure that we have this robust network of providers to go back to once COVID is open. So we do have a large concern that when our providers experience a reduction in revenue, they are very close to the margin of closing and remaining open. So to help our providers remain open, we had to address two different challenge types. The first is we have providers in Medicaid that have additional costs to treatment due to COVID-19. So that is, our current reimbursements in Medicaid weren't able to cover the cost for providers when they had to then incorporate expenses due to COVID-19. And a few examples of our policy approaches to this type of problem where providers kind of face additional costs. Well, one example is we implemented almost immediately an increase in our nursing home payment rates. We've all seen on the news increased cost and very much the incidence and prevalence of COVID-19 in our nursing homes. And so we implemented a rate increase for our nursing homes. And a second example here is that we were able to directly deliver PPE to our consumer-directed and agency-directed care providers, so in the home and community-based services space. The second provider challenge that we have is providers that have reduced revenue because patients aren't showing up, and we all know the reason for that. So many of these providers are indeed struggling to keep their doors open. One clear policy solution here would be to subsidize those providers so that they are able to stay open throughout public health emergency, throughout the pandemic, and then beyond. However, most Medicaid programs face a unique challenge in that lower utilization from our members does not automatically mean we have money in the bank to move out to providers, to provide those subsidies to providers to keep them on. And that's because much of our, for Virginia in particular, much of our money and our Medicaid dollars are paid out to managed care plans in the form of capitation payments that don't vary with utilization, but they, managed care plans get paid a certain amount every month to provide coverage to our Medicaid members. And it will come as no surprise, and I will say that there's a lot of uncertainty here. So again, not surprising, but our managed care plans were not quick to open up their funds and start sending them to providers. So a few policy examples here of how Virginia dealt with this particular provider challenge is that we directed managed care plans to use their existing funding to make something called retainer payments to certain providers in the case where provider utilization declined to near zero. So you can think of this as truly funding to keep providers going, even though there's no utilization, to just make sure that they were still there when, in the future, when COVID-19 happened. Additionally, with a threat. Additionally, we directed our managed care plans to use their existing funding to provide rate increases to services where utilization still persisted, but at a dramatically lower level. So here you think of our, for example, primary care providers that are seeing utilization at around 30% of what they otherwise would have expected. We directed our managed care plan to bump up payments for utilization there to try and get some of our providers to a place where they were experiencing the revenue that they would have otherwise expected at COVID-19, not created this crisis. Now, in the provider space and our policies to respond to these challenges, a lot remains to be seen as to whether or not our response was adequate, or whether or not we, will have, unfortunately, we may see that we do have kind of reduced long-term access as a result of COVID-19. But we did implement policies in hopes that we were able to stave off that bad outcome. And finally, we have the challenge of the state budget. As mentioned, and as Linda so nicely presented previously, our enrollment in Medicaid has grown over 115,000 since the beginning of the public health emergency. And that growth in enrollment comes with a greater need for state funding. Now, the federal government has temporarily increased federal participation for our non-expansion enrolling members, but we estimate that that break-even point, that we will surpass that break-even point with this increased federal funding before the year is over. So while right now the experience and increase in enrollment that we have is more than adequately being covered by the increase in federal funding for Medicaid, we do believe that will stop being the case sometime this year. And when our need surpasses this enhanced federal funding, and particularly when enhanced federal participation ends, Medicaid needs that are left over has the potential to really wreak havoc on our state budget. And when you need to cut Medicaid, there are only really three places to go. You can cut people, you can cut services, healthcare services, or you can cut provider rates. And you tell me which one to cut. They're all really essential components of Medicaid. I'll end by saying that there's still a lot of unknowns regarding our responses to the challenges of COVID-19. But looking to the future, I think the questions we're currently wrestling with are, one, what policies we will keep and what policies we will unwind. As I mentioned, we implemented a fair number, dozens and dozens of new policies to Medicaid in response to COVID-19, and some we will want to keep, but others we will want to unwind and go back to our normal policies. The second question is, how can we make policies, and specifically reimbursement policies for the future, that will withstand public health emergencies? And three, finally, and a rather large one, how will we maintain our Medicaid program in the face of this state budget? So thank you for your time, and I look forward to questions.
Excellent. Thank you very much. And Jeanette Thornton, tell us what is occupying your members and their issues with respect to this pandemic today.
Thanks, Alison. Hi, everyone. It was kind of scary to see my pre-pandemic self on the screen there for a while. I hope everyone's doing okay given the circumstances. So I'm going to talk a little bit about some of the activities and challenges that we've seen facing our member plans and their enrollees throughout the pandemic, and talk about some of the different policy changes that have been taken by both the federal government and states. And then I'm also going to come back to some of the points that Linda made and talk a little bit about how we've been responding to some of these coverage shifts and the economic sort of fallout from COVID-19. So first, I'll speak to coverage. And so America's Health Insurance Plans, we're a trade association, and we represent health plans of a wide variety of types and sizes, from large national plans to small local Medicaid managed care plans and everywhere in between. And since the early days of the pandemic in February and March, there has been a whole host of new changes that health plans have both voluntarily made and other new policies that plans have had to implement on a number of fronts, just to ensure that people could access health care, could access their benefit, and that we were being responsive to this situation that we all find ourselves in. So Ellen mentioned telehealth, and I think this is an area where we have just seen a tsunami of rapid change. It was almost overnight. I'm sure all of you got emails from your personal physicians basically saying, I'm open, I'm available for telehealth. And a lot of this occurred because of a number of flexibilities that health insurance plans were given by both their states as well as by the federal government in order to make some of these rapid changes that address issues like state licensure and what types of services could be done via telehealth, whether it had to be sort of secure technologies or could it be done just on the phone. And these changes really took place overnight in the industry. I mean, it's been interesting. I was talking to a plan in Texas the other day, and they told me, though, that they were surprised when Texas started to reopen that they did sort of see that decline again in telehealth utilization, and they had expected it to sort of be maintained as, but remains to be seen. I think we at AHIP would be extremely supportive of a number of the flexibilities that were given to make changes for telehealth would be maintained, and some of those would require acts of states or the federal government. But we think that's so important. It's certainly another great option for people to have access to their providers, especially in rural communities or in areas like mental health and behavioral health, where it just opens the door to a new world of seeing different providers over the internet, which wasn't quite possible before telehealth. So I definitely think this has been a change for the better, and we do hope that a lot of these flexibilities are maintained moving forward. A couple of other things that I'll talk to are COVID-19 testing and treatment. So a couple of things. I think we're all very familiar in the news with all of the challenges this country has faced with access to COVID-19 testing, which we think is just critical to stopping and slowing the spread of COVID-19 across the country. Congress, very early on in March and the subsequent expansion in April, passed federal legislation that required health plans across all markets, so commercial insurance, Medicare, Medicaid, to ensure that people have access to COVID-19 testing at no cost sharing. And so that's been something that our members have been working to ensure that people do have access to testing moving forward. I think as we start to talk about returning to school, returning to work, fingers crossed for school, at least for me personally, very soon, we've really also seen, though, that existing demand for testing just exceeds the supply. And so we've been working very closely with the labs and other provider and physician organizations to think about what policies can be put in place to ensure that everyone has needed access to testing, as well as whether additional federal funding is necessary, both to support states in their testing programs, but also as for health plans and other employer organizations for schools to ensure that to the extent that they're using testing as part of their strategies, that that's adequately funded moving forward. A couple of other things, we've done some actuarial estimates of the potential COVID-19 treatment costs when someone does unfortunately contract the disease. And originally we were looking at what it would typically cost someone who has pneumonia. And what we've really seen is for people that are admitted into intensive care and ICUs, the costs are extreme. And so this is why having, insurance protection is so important to make sure that people are financially protected. Health plans came out very early in the pandemic and in the emergency and announced that they were going to be waiving cost sharing for people who contracted COVID-19, and so that was not viewed as a barrier for them accessing care. And we've continued to see a number of our plans make extensions of those announcements voluntarily to ensure that that, again, is not a barrier to people seeking care. Several of the proposals in Congress have proposed mandating that COVID-19 treatment be free. That was in the HEROES Act, the House COVID-19 package that passed, I believe, June. Sorry, everything runs together. But that has not been something that's been enacted into law, but a number of our plans have been doing that on a voluntary basis. The other thing, and this gets back to the extraordinary coverage losses that we've seen during COVID, is that many states have required health insurance providers to maintain coverage, even though someone is not paying their premiums because of this unprecedented situation. So that may very well be where we haven't seen some of those direct losses as much, because a lot of states have put in place grace periods so that even though someone hasn't been paying their premium, we are not permitted to drop their coverage, basically. And so I think it'll be an interesting question to see how long states do continue those, because I do think that's ensured a lot of people maintain coverage. Another aspect of coverage requirements have been the PPE program, the PPP program, the Paycheck Protection, I'm sorry, I forgot what the third P is, the PPP program, which has provided funding to employers across the country. And one of the things that we think is happening, I would love to see some more data, it's been happening so quickly, is that we do know that a lot of employers have been using those funds to maintain their health insurance coverage, especially for furloughed workers. And I do think we are coming to a critical point, whether Congress decides to extend those programs, add additional funding, et cetera, because I do think a lot of people have been maintaining their coverage. But unfortunately, that's not something that's going to last, in perpetuity. And so one of the few things that we have been advocating for at AHIP is a fully subsidized COBRA benefit for people who have either temporarily been furloughed or have been laid off. At this point in the year, it can be challenging for someone to change health plans and find a new provider or have to restart their deductible. So we definitely support Congress enacting a fully subsidized COBRA program to help those people, especially those who may be going back to the same place of work, to not have to start over. But to the point that Linda had made in terms of the ACA safety net, we also do strongly support both the administration and Congress taking action to ensure that people who can't get access to COBRA also have access to a special enrollment period to ensure that they can enroll in ACA market coverage. Most states, with the exception of Idaho, who run their own exchanges, did make that available so that consumers who didn't have access to the special enrollment period could go into coverage. That also checks their Medicaid eligibility as well. But the federal government, for a lot of reasons, chose not to do that. And so there have been proposals in Congress that would require that. But just a point on that, though, when people do lose their job-based coverage, they are eligible for what's called the special enrollment period, or SEP, and they can go to healthcare.gov or their state marketplace to see if they qualify for premium tax credit for Medicaid or to purchase coverage on their own. So that's something that's also available. It's been really interesting. I think there's been a lot of debate in Congress, especially over the last week, about whether we will see a fourth COVID-19 package, and a lot of discussion around the types of things that should be in that. We've seen Republicans strongly push for liability protection for entities and employers that are be reopening healthcare providers, et cetera, where a lot of also discussion around extension of unemployment benefits and what that looks like, additional funding for state and local governments. And then we've also been very supportive of Medicaid FMAP expansion, as Ellen mentioned, as well as additional funding for testing, support for furloughed workers through COBRA expansion, et cetera. If you all have a crystal ball, I'd love to hear it. There's been a lot of discussion about whether the Senate even wants to pass the package at all, and whether they will do that by their planned August recess, although this morning I heard that they may go through September. So for us in health policy, woohoo, no August break for us. But so Congress is actively debating sort of what additional policies are going to be needed on this front. And I think they are considering a number of things in the healthcare arena that I mentioned. So I think with that, Alison, I'll turn it back to you, and I can certainly talk more during the questions.
Great. So we do have several. One question to Linda is, what recommendations do you have for marketplace coverage at this point in time? Is there anything that comes out of your results that you would wrap into a recommendation package?
Well, I think one of the things that I am concerned about, Jeanette mentioned that when people lose their employer-based coverage, they do get a special enrollment period, and that is true, but it is a limited period of time, right? So it is 60 days, and generally it takes longer than, just a one-shot deal to get through the process and get your eligibility verified and choose a plan and get enrolled. And my concern is really that is several-fold. Number one, that most people don't recognize that there's a limited period of time that they have, and that prioritizing that is a big deal, particularly when folks are losing their employment and they're more worried about initially getting signed up for unemployment insurance benefits, food stamps, the things that are kind of front and center. And if you're not actively ill or in treatment, getting enrolled in health insurance coverage is not your first thought, it seems. And so as a consequence, I'm quite worried that that limited period of time is really going to work against people, as folks were talking about earlier, as those PPP benefits evaporate if they're not extended and more people are losing their employer-based coverage. The federal government has really done nothing as far as outreach and beefing up enrollment assistance to both let people know that this coverage is potentially available to them, either through Medicaid or the marketplaces, and that there's a time period that, limitation. And so you really want to look at this. So I would both require a very concerted outreach effort on this. I would expand the special enrollment period for people losing coverage for well beyond the 60 days. Perhaps, given what's going on through, throughout the crisis, at least towards the end of the year. From my perspective, having that open enrollment period, for the federal marketplace states would have been a very worthwhile step, so that people who had been uninsured before could rethink whether or not it made a lot of sense for them to get coverage given what's going on. I also think expanding the subsidies during this period of time for marketplace coverage would be a very worthwhile step. We know that the subsidies through the ACA have made coverage more affordable for a lot more people, but as income goes up, even through that 400% of poverty range, the subsidies get less and less generous quite quickly, and that's one of the reasons why a lot of us have been talking about expanding these subsidies beyond where they were. And there's a cliff at 400% of the federal poverty level, which is still not high income. So I think, taking the opportunity now to make that at least temporarily, hopefully eventually permanently, those subsidies more generous would make a really big difference in terms of coverage.
Thank you. Thank you. Jeanette, can you explain something to us, please? So we've been reading about how individuals have been putting off their care and volume of care has declined, and there's been some bounce back, but not to levels that we've seen before. Can you explain how that affects insurance premiums, focusing on the small group and individual markets?
Sure, that's a really good question. And I think this is an area where it does vary across the country. And so obviously, everybody knows that most people have been deferring a lot of health care starting in March through today, as long as they possibly could, to ensure that themselves and their family remain safe. And so that has meant that health insurance providers have been spending a lot less on provider services during the pandemic. And so there's been a lot of activity around whether a lot of our plans have announced different rebates or premium holidays or other types of programs, especially in the group market, so that those additional funds are going back to their enrollees. But I think the question has been for us, and I think you can bring like 5 actuaries in the room and they're all going to have different answers, is in terms of when does that bounce back occur? Does it occur this fall, or is it really care that's ultimately never made up, or does it bounce back in 2021? And so I think I would have hated to have been a plan actuary setting premium rates for 2021, because you're really having to make a lot of assumptions around what that particular thing will be. I will say, though, that if plans do miss the mark in terms of what they spend on medical care versus their administrative costs, there is something called a medical loss ratio that plans only are required to spend 80% of their premium dollars that they take in on medical care. And if they don't, that money is returned to consumers via the MLR rebate process. There has been some guidance that has come out from CMS, at least for the 2019 year, which obviously was pre-pandemic, that you could give people their rebates earlier, because people, unfortunately, given the economic circumstances, we want to make sure people have those funds as soon as they are available. And so that is one option. And I think we're awaiting some guidance on whether that will also be the case for 2020, when we may see some bigger MLR rebates because of what you just mentioned. So those are just a couple of points. It's a very complicated technical area, but we will ensure that people will receive those. If those marks were sort of missed because of that deferred care, that will be returned back to our members.
Excellent. Thank you. And I think, Ellen, we can pitch this question to you. Of course, there's been, and Linda mentioned, evidence that some of these job losses have occurred at state and local government levels. Can you talk about the picture from your standpoint? Do you think there's going to be additional federal funding to support state and local governments? Is that likely to come from Congress, do you think?
Well, all I can say is that we certainly hope so. In terms of prognosticating here, I will leave that to others, but I will firmly say, speaking from a state perspective, speaking from the Medicaid perspective, we in states we have to operate on balanced budgets. That's not a thing in the federal government, and we know, and we're staring down kind of, we budget in Virginia, we do biennium budget, so we budget out for, 2 years in advance. We had, in the state of Virginia, we had passed a pretty banner budget at the beginning of this year, of 2020, that included a lot of reforms and new spending, because Virginia really was seeing increased revenues and feeling great economically. But, the governor, while that budget remains passed, Governor Northam came in and unallotted, as we refer to it, but essentially took away all the funding for the new program, so that we could really see how our budget plays out. And we are seeing, we are not expecting, we have a special session coming up in about 2 weeks, a little bit over 2.5 weeks. And, we are not expecting that those new initiatives get funding, and in fact, kind of the opposite, right? That we are facing, scenarios in which we are having to model, 5, 10, 15% cuts to our programs, and what does that look like? And so for us, particularly, and increasing federal funds through Medicaid is a pretty efficient way for the federal government to get funding to states. And so, we, along with kind of our state Medicaid trade association, are very supportive of an increase, a greater increase than currently exists, an increase in kind of that federal participation, that federal match Medicaid. So we can, this pandemic is kind of, hitting us double in the healthcare space, right, and in the Medicaid space, right. It has to do with budgets and revenues, but it also has to do with health and individuals needing health insurance, needing health care through Medicaid. And so without that kind of additional help from the federal government, I do think that all states will be in a pretty rough position.
Right. Thank you. Thank you for that sobering reply. Linda, can you tell us a little bit about projections for the Medicare Trust Fund in the context of this pandemic?
So not actually my area, so I have not looked at that. Our work so far has focused on the implications for the non-elderly population. But I think all conversations related to decreases in revenue have implications for the trust fund. The conversation that seems to have quieted down about cutting the payroll taxes at the federal level also would have implications for the Medicare Trust Fund. So I think that it's obviously, I can't give you estimates about it, but obviously it's a concern, depending upon how quickly revenue comes back and employment comes back, we could have a very significant change in the soundness of the trust fund.
Right. Jeanette, we've talked about telehealth here it's come up a couple of times. And there have been studies on the primary care, through the primary care collaborative, for example, showing that some primary care practices still struggle with telehealth, adding to administrative burdens. Is there something in particular you see that the plans could be doing? And related to that, on the commercial side, did plans use retainer payments in the same way Medicaid plans did or not? Medicaid programs did.
Sure, I'll take the second half of your question, Alison, first. So, a number of our plans did do advanced payments to providers. Some states looked at that in terms of requiring that as well. And so, yes, I think they've supported their providers, especially on the primary care side, as well as helped ensure that providers have awareness of the different federal provider funding available as well. So sure, on the commercial side, on the telehealth, just a couple of things. Definitely rapidly at the beginning, there were a lot of benefit changes that plans made to just ensure that people had access to telehealth, especially at no cost sharing. That required some changes in rules from the Internal Revenue Service because of high deductible health plans, and also made sure that there was access to a greater array of different types of telehealth benefits. I think pre-pandemic, most of our member health insurance plans would provide telehealth through prearranged portals or different kind of contracted vendors, which are still in play and are a very helpful resource out there. But I think what we saw as a result of the pandemic are individual providers sort of each going out and establishing their own processes and technology to support telehealth. So I think that's been it's been important, but it's been challenging just because every one of those is a little bit different and has worked in a different way. But I definitely think that the couple of key issues for plans is just ensuring that that's sort of documented correctly and coded correctly so it can get paid, and as well as sort of dealing with this. It does change visits in some respects because for many, think about a primary care visit, it ultimately still results in labs or other sorts of services that can't simply be done via a I'd love to get a lab test via telehealth, but unfortunately that doesn't exist yet. So having to sort of separate them out and make sure that a visit sort of sets forth the initial sort of guidance, and then there's those other steps that take place in the way as well. So I'm sure we're all still learning about sort of the best way to sequence those things and to make sure that that's going to be productive long term. And I think right now is a great time for us to sort of take a step back and look at what worked and what didn't, and look at making some changes moving forward. And I think that's one of the things that we're looking to do. And I'm hopeful there's a lot of great research that comes out of this too, to provide us with some more thorough lessons learned so that we can think about what worked and what didn't moving forward.
Yes, I fully agree with that. It sounds also like on the Virginia Medicaid front, there's been some innovating around avoidable emergency department visits and some policy changes that have recently gone into effect. Ellen, can you kind of shed some light on those? So kind of what is it Medicaid is trying to achieve at this point?
Yeah, so Medicaid has taken two approaches to try and tackle avoidable ER admissions, but also avoidable hospital readmissions. And we've done this on two fronts. Number one, we've tried to tackle this through our managed care contracts. So we have created avoidable hospital admission policies and also avoidable ER policy measures with each one of our healthcare plans, and have tied an improvement on those measures to the achievement of improvement on those measures to the earning back essentially a 1% withhold of all of the capital tuition payments that are paid to the plan. And so I will note that this was starting July 1 is the first year of this program and this measurement. So while we have not made any announcements in terms of how this policy is affected by COVID-19, we do suspect that we may have to make some changes to this policy because of COVID-19. So our intent is to hold plans and our managed care plans accountable for care and for outcomes that they actually can be held accountable for. And with COVID-19, that has meant some different things for us, and we have to make changes. On the other end, our General Assembly, our legislator in Virginia, did pass a few payment policies that are aimed at kind of the payments made between managed care plans or Medicaid and providers. What I just mentioned was an arrangement between the payments between the Medicaid program and our managed care plans. The General Assembly passed payment policies aimed at payments between Medicaid and managed care plans and the providers themselves. And those policies begin as well on July 1. And those are kind of direct reductions in payments to emergency rooms and also hospitals when individuals come to the hospital or the emergency room with conditions that were otherwise avoidable. I think I will imagine some potential changes to those policies as we move forward. But you got to start somewhere with your policies, and we'll have a lot to study.
Right. Well, having trouble unmuting myself, I think.
We can hear you.
Right. Okay, great. I'm back. Excellent. So finally, Jeanette, we're hearing researchers are predicting greater consolidation on the provider side potentially coming out of this pandemic. What do you think the response is likely to be on the payer side? Are you anticipating any consolidation or market restructuring on that side as well? And I'm not sure that just went through. Having a little difficulty here. Let me just check in with technology here. Fascinating.
There we go. I heard your question.
Okay, great.
A little bit.
Glad you're back.
I don't know if it's my kids on YouTube or what. I take the blame. So the question was about primary care providers and sort of consolidation. So that is something that we're very concerned about, which is why I think a lot of our provider relief has focused on those providers and ensuring that they do have that financial lifeline. So it's certainly something that we're going to be watching, and definitely it's sort of shown how fragile some of our providers are and how we need to think through and advance policies that will support them moving forward. And now you are on mute. I can't.
Yeah. All right. So in our last moments here, let's start with Linda. What health policy issue are you going to track most closely in the next few months? And we'll have each of you answer that question. And again, I would just want to thank you so much for participating. Linda, what are you going to have your eyes on?
So we're going to definitely have our eyes on enrollment in the different programs and the variation across states in terms of the ease and the facility with which people are able to change coverage when they need it. So that's going to be our main focus. But we also are, along with everyone else, very interested and concerned about overall costs and how that's going to play into premiums in the coming year. As Jeanette said, there's a tremendous amount of uncertainty about what's going to happen with the path of utilization. Most of the insurers that we have spoken to and our work have indicated that they think that the costs are going to basically level out, that the premium increases next year should not be large. But obviously, everybody is banking on, predictions of, I think, getting back to some level of normalcy in the coming months. And a lot of that depends very much on vaccines and access to that. And the other issue that we're going to be looking at is the way to pay for testing and going forward, and how the variation in need for the frequency of testing across different industries is going to impact costs and access depending upon where people work and what their insurance situation is.
Great. And Jeanette, what's topmost on your watch list?
So we'll be very closely watching whether Congress supports any additional support for providers, for state and local government, for Medicaid, for testing, for all of these things that we talked about. We're also, gearing up for a presidential election, which is a whole other discussion, a whole other webinar. Seeing how, this current administration is really rapidly working on a number of final regulatory proposals, which are taking a lot of our time, and thinking about how those would or wouldn't change in a second term or a new administration. So
got it.
That's what.
And I just heard you say we've obliterated your August holiday.
Not you, but Congress may. We'll see.
We the nation, yes. And Ellen, what's on the top of your mind of things to watch?
So I will go with an and. So definitely what was just mentioned, but I'll try and leave us with a positive note. And I would just say, during this time of a crisis that has actually created a lot of new, policy changes in Medicaid and other places, I think that, that's often kind of the inertial energy required to sometimes make policy changes that you might have wanted to do in the past or not, had the focus on. And so I am looking forward to figuring out what policy changes we've made and can sustain that may actually be more beneficial to our members' health. So.
Great. Thank you again, panelists. It's just been a real pleasure to spend this hour with you. And we hope to have you back and figure out what we've learned from all of this. Thank you again, and have a great rest of your summer.
Thank you very much. Take care.